Good afternoon, everybody. Welcome to a special live Facebook event from the College of Science at Northeastern University. Our broadcast today is called When Words Speak Louder Than Numbers, Communicating the Science of COVID-19. As the pandemic continues, we find ourselves asking scientists to do more than simply study the virus. In state houses, in cable news interviews, and on social media, they're translating their data into insights, recommendations, and even advocacy. But with so much confusion and mixed messaging still remaining months after the outbreak first occurred, we begin to wonder, how is COVID-19 being communicated at the highest levels of government? What does the public know and not know about the virus, and who's responsible for fixing misunderstandings? Should scientists be on the front lines of advocacy? Hello and welcome. I'm Mark Patterson. I'm Associate Dean for Research and Graduate Affairs in the College of Science at Northeastern. I'm also a faculty member who works on global changes in the underwater world. I have an appointment in marine and environmental sciences, as well as civil and environmental engineering. I'm fortunate to have today one of my colleagues from marine and environmental sciences with a joint appointment in physics, and that's Sam Scarpino. He's an assistant professor and also in our Network Science Institute. He's also head of the Emergent Epidemics Lab here at Northeastern. His work modeling real-time data in China gave us an early look at what measures were most effective to slow the spread. He's been published in Nature, as well as contributed to countless science stories in the New York Times, National Public Radio, National Geographic, and many more media outlets. Sam, thanks so much for joining us for this important conversation. And
Thanks for having me, Mark.
Yeah, it's great to have you here. Those of you, by the way, at home can join the conversation here on Facebook Live. Please submit your questions in the chat, both during and following the broadcast, and our intent is to get to as many of them as we can. So to start, Sam, let's start with your work. Your research has concluded that we as a nation were too slow to act in curbing the spread of the virus. My first question is a retrospective one about preparedness. Do you believe the policymakers and the public were not ready to hear the science behind COVID-19, or that the scientists themselves were not prepared to communicate it, or was it a mixture of both?
There were certainly a lot of complexities early on in the pandemic that led to the slow response in the United States and many other countries. One aspect was certainly because this was a novel disease, we were learning about it, the biology, the sociology in real time as the outbreak started to unfold. That's one of the reasons why the messaging around things like face mask wearing, which I'm sure we'll talk about later in the hour, has changed because our understanding of the importance of that type of intervention has shifted. However, when I think it back to early February, March, it was very clear that the disease was spreading rapidly in China, that it was starting to move out of China into surrounding countries. We were starting to see early cases in the United States. And that was the opportunity to ramp up testing and to focus on testing individuals who met the case definition, meaning the symptoms that are associated with COVID, as opposed to just focusing on travel history. So what we saw retrospectively is that a number of early introductions in the West Coast, Seattle, California, were stopped with public health measures. We identified the cases, we performed contact tracing and isolation, and we prevented the outbreak from taking hold. However, once the pandemic was seated in Europe and we started having cases come into the Eastern United States, we were no longer finding those individuals because we had both a low capacity to test and we were focused heavily on China and we're missing those individuals that were traveling through Europe into the United States.
Yes, we live in a hyper-connected world now. The Global Resilience Institute at Northeastern has been giving advice to governments about how to be resilient in the face of these unexpected ripples. So your estimation, though, is that your colleagues who are modelers and infectious disease experts that their messaging wasn't delayed, or there wasn't a break put on it, that it really was perhaps a disconnect between two ways of thinking about the world. So I guess the next question I'd like to ask you is, in a situation like this, do scientists need to become advocates for using data if policy issues or if government organizations are either unwilling to understand the message or unwilling to implement the necessary health measures, as some of the states apparently did early on, as you just mentioned, in the early stages of the disease? So is it fair to ask scientists to be advocates, I guess, is my question for you.
I think it's certainly an expectation that scientists should have of themselves, that if there is an opportunity and a need to advocate on behalf of the research that you're involved in, then those kinds of advocacy methods or approaches are important. However, it's impossible for almost anyone to be an effective advocate, an effective communicator of science overnight. And so one of the things that we're seeing as an increasingly important part of scientific training is ensuring that individuals have the science communication training, the advocacy training, but importantly, that they have the support network around them, because most of us are not and will not ever be experts in public policy and advocacy in science communication. And so, for example, the Northeastern News team has done a fantastic job, as have the news teams from around the universities in the US and globally, at helping bring the scientists and the journalists into the same environment so they can communicate, but then also helping the scientists facilitate more effective communication and more effective advocacy. So I think you really have to be building that skill set and building those networks of collaboration before the pandemic hits, so that you're not trying to implement all of this as you're also learning about a new disease and trying to stop it in its tracks.
So I'm going to return to this question of how you be an effective communicator if you've got important science to communicate, because that's an important one. But we did get a great question from Gabby Hernandez via Facebook Live. In essence, she asks or points out, and this is a fact, that the United States is significantly behind other countries, and we've got very lax and uneven state policies with regard to managing the health aspects of this crisis. So her question is, do you think we really need a command and control at the national level to deal with something at the scale of a country? And in some sense, we're a whole continent. The United States occupies a good part of North America. So are you an advocate for national control as opposed to regional, state level measures?
One of the challenging aspects about the COVID-19 pandemic has been the essential absence of leadership at the federal level. So we know that the CDC has really not been a daily feature as they were in 2009 with H1N1, in 2015 for Ebola, in Zika virus as it was hitting our continent. And so that sort of void is also part of the reason why many scientists have had to step up into these advocacy and public policy roles, because the traditional venues that advocacy is communicated, where the science is translated into policy, have not been available. And what we're seeing is the need for federal coordination when it comes to implementing things like mask wearing, testing, approving testing, determining what are safe and effective measures for keeping cases from growing into large local epidemics. All that being said, of course, given the vast differences across the United States, you think back to April, as Boston was experiencing one of the largest surges of COVID-19 in the globe, there were parts of the US like Arizona, Texas, Florida that were not seeing very large outbreaks. And now, of course, things have flipped, and Boston is continuing to see day over day, week over week declines in cases while they're spiking in Arizona. And so we need a system where there's federal level coordination, but also flexibility at the local level to respond to differences in what's happening, in people's neighborhoods.
So that patchwork must present quite a challenge to the modeling community. I wonder if you could tell us a little bit of the modeling approaches you and your team have been taking, and for example, how do you scale up for helping the mayor of Boston, to then helping the governor of Massachusetts, to then helping the regional group of governors in New England manage something of this magnitude? Can you tell us a little bit about your modeling approach, Sam?
The first step that we took from the modeling approach was to begin building large-scale data sets around COVID-19. One of the things that we know from past outbreaks, from past pandemics, is that it's very difficult to get high-resolution, accurate, validated data, especially early on during the pandemic, to power those models that we've been seeing, across the front page of the New York Times and the Washington Post. So we stood up a volunteer consortium across the globe, institutions like Oxford and Beijing Normal University and Northeastern, University of Washington, collaborating with technologists at Boston Children's Hospital, Health Map, Mapbox, and now Google, to build a comprehensive data set around COVID-19 to power these mathematical models. In terms then of actually scaling, again, part of that scaling is the preparation ahead of time. So you think about researchers at Northeastern University like Alessandro Vespignani in the MODS lab. Vespignani and his team have been building towards COVID-19 in terms of their response to past outbreaks for decades. And so they have the computational infrastructure, they have the political experience in terms of navigating the various state, federal, and international organizations to be able to rapidly deploy these kinds of tools. So it's a combination of building the data sets, tailoring the models to the specific policy questions that affect Boston, affect Massachusetts, affect the United States, affect our global community, but then also having the frameworks and foundations in place so that you're ready to deploy even before the pandemic happens. Because again, similar to it not being effective or efficient to have to learn science communication on the fly, certainly we've seen a lot of examples of the quote armchair epidemiology. And it's not that we don't want more people participating in epidemiological investigations, it's that it is very challenging to instantiate all of these tools in real time during a novel pandemic.
So data are obviously vital for modelers in order to see how you're doing. Can you tell me a little bit more about the open source data that you and your team, it was a global team really, it was amazing that you were in some sense hand curating the acquisition of some of that in the early stages. So tell us a little bit about the open, essentially a crowdsource from your community of scientists and medical experts out there. And then my follow-up question is, why would this data not be available already with modern healthcare systems?
I'll answer the second question first. So why the data would not be available. It's the kind of question that would require essentially a dissertation to fully answer, because you imagine, okay, why isn't the World Health Organization able to collect and share epidemiologic data? It's part of their mandate, but they have to negotiate with all of their member states, many of whom barely get along with each other, and all of the data sharing agreements, the collection, what can and can't be accessed by whom and for what, has to be negotiated. And typically it has to be negotiated as the pandemic is unfolding. We saw this during Ebola, we saw this during H1N1, we saw this during Zika and chikungunya. So we were anticipating the complexities around data sharing by these non-governmental organizations or governmental organizations like the CDC. So a similar kind of complexity in terms of data sharing as it interfaces with politics affects the CDC's ability to share information from state and local health agencies across the United States. However, what has changed since 2009 is that vast amounts of health data epidemiologic data are reported through news sources, through public channels coming out of state, county, and city health departments, national health departments. And so two individuals in particular, Moritz Kramer, who's a research fellow at Oxford, and David Piggott, who is an assistant professor at University of Washington, realized that we needed to begin entering these data ourselves into an open source comprehensive database. And those individuals grew to what is a team of now over 100 people. We've entered about 2 million records, individual records from 150 countries. We have brought on engineers from google.org to help us scale the technology and computational infrastructure behind the data. We brought on brilliant designers and product managers. So this name that none of us can remember, the Open COVID Data Working Group, I think 2019, we're going to be global.health. I don't think I'm allowed to say that yet. I forgot we're on live, but we were rebranding ourselves under this new kind of international consortium, of which Northeastern is a major part, to not just provide data for COVID-19 over the coming weeks, months, and probably years, but also for the next pandemic that we know is coming in the future.
That's amazing that you've got more than 2 million records. I mean, isn't the total caseload that's reported on that aggregator site run by Johns Hopkins only around 4 million now, or is it more? I used to be obsessed with checking the numbers there, like a lot of people were, but that's a significant fraction of the entire database that you have curated. Is that correct?
Well, similar to checking the numbers every day, one of the things I was telling people was that it's like your stock portfolio or retirement account, assuming you have one, which is you shouldn't look at it every day. In fact, you should definitely not be looking at it right now. But we shouldn't be looking at these numbers every single day. It's why we have the 7-day rolling averages, the 14-day rolling averages. But of course, like everybody else, I wasn't listening to that advice, and I was refreshing. I think the number's up around 4.5 million. We've got around 1 million records that we think are deduplicated, validated, and as a part of our open source offering. We've got about another 1 million that are going through quality control checks right now. Our goal is really to have all the publicly available individual level data merged and aggregated, ideally by the end of the summer. We've identified all the different sources of data that are being reported. We have engineers that are building interfaces between those public reporting systems and our database backend. We're building the APIs that people will need to pull those data into their own visualization or analytics tools.
So I assume part of the value of having a data set like this is you get a time series, and so other investigators can ask questions, retrospective questions about how this unfolded that may guide future policies and allow us not to be in the same situation when the future pandemic you mentioned happens. Is that part of the goal of having this curated data set?
That's certainly part of the goal. And you mentioned our work in China around non-pharmaceutical interventions. And the data that we used were data that we had manually entered into our database. And they were critical for our ability to identify the efficacy of these non-pharmaceutical interventions. So we were capturing information on not just when somebody was PCR tested and positive for COVID, but where possible, when they actually first reported symptoms, which, as you might imagine, that window of time shrinks dramatically as the country ramps up testing between a week to 10 days between symptom onset and PCR confirmation, down to 3 or 4 days once China got their system ramped up. We had travel history, so we could see individuals that had travel history back to Wuhan, that had visitation history back to the seafood market that we think was one of the early hotspots. And then we could see that travel history kind of changing to local transmission as the lockdowns go into place. And then we could see the case numbers falling off as the non-pharmaceutical interventions took hold. And so having those sort of rich individual level data with symptom onset, details of the symptoms, travel history, age, those allow us to paint a very clear picture around what's working and what isn't working. It then allows the policymakers to make the most informed decisions possible around how they feel we should be intervening.
Returning to our situation here in the US, Sam, the news cycle in the last 24 hours has been dominated by the surge in cases in about half of the United States. This is on everyone's mind, given that we've seen changes in restrictions state by state and community by community. The weather is now nice in many parts of the United States. People are outside. What's your read of the national situation with respect to what your models are predicting? Are we still in the first wave and we're seeing another bump, like a camel's double? I forget which camel's one's got the two bumps, but
Yeah.
you know what I'm saying. Is that what we're having? And then the second part of my question is how, as you like to remind me, we're still learning things about this pathogen all the time. How important are understanding the modes of transmission, and in particular the aerosol transmission just through being in the same airspace as somebody? So if you could give us a view, what's your view on what's happening in the U.S. right now, and what's in store for us in the fall, and how does the whole aerosol transmission figure into this as we go back to work?
For seasonal influenza, the typical pattern in space is that flu shows up in all of the big cities in the US at about the same time. There's important effects of humidity, there's north-south gradients in the number of cases, but it's highly synchronous across the United States. For novel pandemics like the H1N1 pandemic in 2009 and like COVID-19, there's a lot more spatial structure in terms of where there are cases, because you have the first cases for COVID showing up that take hold in New York City and Boston on the East Coast. For 2009 H1N1, it was South Texas and Southern California, and you see these waves spreading out across the country. And so what our models were predicting back in March, April, was that part of the reason the lockdowns were so important is that we needed to make sure that the entire country doesn't synchronize with respect to COVID, because then all of the healthcare systems will be overwhelmed at the same time, which is what we were doing with the flatten the curve, is preventing the healthcare systems from being overwhelmed. And so we were very aware of the likely scenario that we would see outbreaks in New York City, Boston, the East Coast, the places that had the first cases. And then we would likely see outbreaks in other large cities in the US and comparatively more suburban and rural areas later into the summer. And so this kind of pattern is almost exactly what we were expecting. We, of course, variability in terms of magnitude in the predictions, lots of uncertainty, but in terms of how it unfolds, moving from whichever coast that arrives at first into the interior of the country, into the southern parts of the country, is what we anticipated, given the way that pandemics in the past had unfolded, and given the way that these mobility patterns were changing. We know that mask wearing is highly effective at stopping transmission. We now know that probably 80% of transmission events result from 10 or 20% of people that are infected. And so a combination of reducing gathering sizes and mask wearing will dramatically slow down COVID-19. So when we see states like Arizona, Texas, Florida opening up, having large gatherings, not enforcing mask wearing, given that they hadn't had an outbreak yet, it's essentially a perfect storm for generating the kinds of massive waves that we're seeing now. In terms of whether we're in the first wave or the second wave, one of the things that is important to think back to about a month ago, which for probably most of us feels like decades ago now, if you looked at the entire United States, it looked like the number of cases were coming down, that we were coming down the other side of the peak. But if you subtract out New York State from that curve, the rest of the country was still going up. And it was just New York State that was dragging that whole curve down. And now what we're seeing is the US is going back up again. And it's going up because of what's happening in Arizona, what's happening in Texas, what's happening in Florida. But there are many other parts of the US, like Massachusetts and Boston and New York City, that are still continuing to go down. There are states like Maine that have really been able to keep the outbreak in check, Hawaii. And so one of the problems with aggregating all the way up to the national level is, yes, at the US level, we may be experiencing this sort of camel's hump. It's not clear whether we're in the first wave or the second wave, or whether there will be a clear difference between the first and second wave. But if you look at the cities, if you look at the states, it's very clear that Boston is exiting from its first wave, and that Phoenix is right in the middle of their first wave. Now, the question around the fall is one that's very, very hard to answer. It's really going to depend on mask wearing. It's going to depend on what decisions are made around how to reopen different parts of our society. It's going to depend on how this coronavirus will interact with influenza, something that we don't know very much about for this particular coronavirus. It's going to depend on the specifics of how transmission works in terms of our social network structure. That affects quite a bit where you might have heard of the herd immunity threshold, which is the fraction of individuals that have to be immune for there to be a low chance of an outbreak turning into an epidemic. Where that herd immunity threshold is, it matters quite a bit in terms of how the transmission is structured in the social networks. These are all questions that we're learning right now and still don't have a great answer for. Just to finally come back to the aerosol transmission, it's very clear that masks are effective. Even the non-N95 masks, so just the surgical masks or the bandana, that suggests that while aerosol transmission can happen, it's probably not the primary route because those aerosol particles would be too fine to be filtered by those masks that we're wearing. I think we're still learning quite a bit around what the actual risks for transmission are, although we know that being in an enclosed space with the windows shut, and especially if you were singing or talking or doing any of those sorts of things, those are the really high risk situations for transmission.
Just a reminder to our audience tuning in that we are taking questions through the chat. Again, this is a Facebook live event from the College of Science at Northeastern University, and we're here with Sam Scarpino, who's one of the world's experts in modeling diseases like COVID-19. And again, thank you for being here with us today, Sam. I wanted to return back to the fact that many of you have become overnight media sensations because this has turned into a pandemic, and that this is challenging because scientists often don't get media training. I have a friend who's works in the area, and he was just writing a blog post for his friends and family in another country, and he did a little common sense analysis about the aerosol transmission that we were just talking about. And before he knew it, his family blog had more than 18 million views. And the next thing he finds is that he's being asked to talk on CNN about this, about just his meta-analysis of a few papers that he found on the internet. Can you tell us a little bit about your own training and what you recommend? Do you recommend that scientists get media communication, and what sort of strategies have you had to use when you've been talking to the general public? And then do you change your strategy as opposed to a general public information session when you're talking to a decision maker? I'd be very interested in hearing that.
Certainly, ensuring that scientists, academics in general, are provided the sorts of professional development that include media training, general communication, interacting with policymakers. I think we need a lot more of that in all of our pipelines around graduate education, postdoctoral work, for junior faculty, even faculty that have been in departments for decades, but maybe all of a sudden their research is landing on the front page of the New York Times, and they need training in how to interact with journalists, what to expect, what not to expect. I was very fortunate for a number of reasons. The first being going through a postdoctoral fellowship at the Santa Fe Institute. They provide a lot of professional development. It's a part of the fellowship program that Piero Midyar supports through the Santa Fe Institute to ensure that the postdoctoral fellows have media training, have science communication training, that they build relationships with journalists. So Santa Fe Institute had a fellowship where they would bring science journalists into the Institute for a semester, for a year, just to interact with the researchers there, build relationships, and get ideas for future pieces that they might write. And so I think having that kind of training is a critical part of one's professional development, and something that we really need to make sure we're supporting students, junior faculty, senior faculty. The second then is to make sure that we have the support that we need from our own internal experts. I mentioned Northeastern News already. They've done a fantastic job of helping me navigate the landscape of interacting with the various media sources, understanding what to expect when I'm getting ready to go on to a live television broadcast or a live radio show, what to expect if it's going to be pre-recorded, what kinds of questions to ask and answer. All of those sorts of things are really critically important, to make sure that you have that support network as you're going out and learning how to do this for maybe for the first time. I will say it's been very interesting. I've certainly had a lot of opportunities to interact with the journalists. It's been very humbling to see how much energy, expertise, creativity, wisdom they've put into communicating all of the information around COVID to the public. However, some of my friends have really exploded in terms of their kind of presence. So you have individuals that have hundreds of thousands of followers on Twitter now, who I went to graduate school with. That we realized that some of them have more followers than like the past head of the CDC and those sorts of things. And so, as is everything with life, there's always gradations where it feels like, you are experiencing something from a media perspective that is totally uncharted for you. And then you see your friends and they are, literally on CNN every single night. And so it has been a steep learning curve, but we've certainly benefited from organizations like the Santa Fe Institute, like Northeastern University, providing those professional development resources and providing the expert staff to ensure that the researchers have the support they need as they're interacting with the media.
Well, I think that it's definitely true. The public is hungry for information because it literally affects us all. We're all in the same boat on the whole spaceship Earth at the moment. Just to follow up on how you communicate science, perhaps maybe when you're talking with someone who's in a position of power, like a governor or a mayor, how do you get over the comprehension calculation issue you may have with someone who's, a social scientist or a politician that doesn't think in terms of models? Do you use animations or graphics? Do you have to package things in a digestible soundbite or phrase, or is that does that present a danger, and that oversimplification may cause the subtlety of some of your what if scenarios and decisions that could lead down one path or another? How do you navigate that?
Yeah, you asked that question in the last round, and I forgot to answer it. So thanks for bringing it up again, because it's a very important question. And I'm going to give a similar answer to what I think is becoming the emerging theme of our conversation, which is, so in graduate school, I did my PhD actually in ecology, evolution, and animal behavior at the University of Texas at Austin with Lauren Ansel Myers. And Professor Myers is one of the pioneers in the application of network models to infectious disease outbreaks, foundational paper on SARS in 2005, but also one of the pioneers in terms of interfacing with public health officials with decision makers during pandemics. And so I was fortunate to learn as a graduate student some of the ways to effectively interact with policymakers. We were also very fortunate that the National Institutes of Health had a program called MIDAS, Models of Infectious Disease Agent Study, that interfaced mathematical modelers with policymakers, that embedded mathematical and computer simulation modelers into the CDC during the 2009 pandemic. And so you build this set of experience around how to communicate uncertainty, how to communicate the model structures, how to communicate the assumptions, the scenarios you're considering, all of the things that the climate scientists have also had to learn. The epidemiologists had an opportunity to do that through this NIH program. And so most of us have been working on this, building these relationships with policymakers, with public health officials over the past 10 or 15 years, building a common language, a common understanding of the models, a common way of communicating that uncertainty. And so again, that groundwork, that framework that you lay ahead of time is really what sustains you when things get stressful and complicated, because you already have that trust, you have those relationships that have been built. I think the most important part of communicating with policymakers is to really make it clear, and this is something, again, that Professor Vespignani Northeastern is such an expert at, to really make it clear that we are providing information, data points, model forecasts to aid and support decision making, that we are not making policy recommendations. That is not the role of these models. It's not the role of the mathematical epidemiology that we do. It is to paint a picture and provide the resources that are necessary for the policymakers to make the decisions around how they want to move forward to best protect their populations and also try to support the economy and ensure that individuals have the health services that they need. So I think that combination of training, building those relationships and trust over many, many years, and then also really understanding that what you need to communicate around a lot of these models is that they are a tool for aiding in decision making. They are not a policy recommendation tool. That's a different branch of science, is really important for the kind of expectation setting around interacting with the policymakers.
I know in the earlier part of the epidemic, you were working with Boston, trying to predict how much capacity was going to be needed in ICUs, et cetera. Now that we're having this second load on the system, tying back into policy and how a decision maker makes a decision, has it been your experience that for something like this, the policymakers are most influenced by whether they break their local healthcare system? Are they influenced by the absolute number of deaths? What are the metrics that are most useful or most impactful as you're presenting your what if scenarios from which people have to make real world decisions about opening and lockdowns, et cetera?
One of the things that was very clear, both from what happened in Wuhan, China, what was happening in northern Italy around Milan, and what the models were saying, is that the risk of hospital systems being overwhelmed was very real. And so communicating that to policymakers, to hospital networks, was critical. In Boston, we did succeed at flattening the curve. But the real reason that we also didn't go through our ICU capacity is that the hospitals were able to open up bed space. Most hospitals run at between 95 and 99% full at any given time in the ICU. And in Boston, states like Indiana, Maine, New York, they got those occupancy rates down to 60, 70, 75% in order to accommodate those surges in the number of COVID-19 cases. And so really communicating to the policymakers that a very real and possible scenario was one in which the hospitals would be overwhelmed allowed them to weigh the costs and benefits of emptying out those intensive care units. And so, why is that a cost? Well, those beds were supposed to be filled with individuals that need cancer surgeries, for example, that had to be put off because of the need for the COVID ICU bed. So there's a real health cost. There's also a real economic cost because those hospitals rely on income from the beds being filled. Their economic forecasting models have a certain assumption around what the capacity is going to be in terms of how close they'll be to capacity when they're forecasting out their budgets over the coming years. So all of these kind of interconnected issues have to be weighed. And so it was critical that we made it clear early on that a very real scenario was one in which the hospitals would be overwhelmed. And I think now what we're seeing is a situation where we need to be planning for how we safely relax measures to try to bring parts of the economy back online, to bring parts of our social life back online, but then also what kind of indicators we need to be looking at if there's going to be a second surge coming in the Boston area, so that hospitals have the 2 or 3 weeks they need to prepare. And so, while the rest of the country, Arizona, Texas, Florida, is looking back at Boston and back at New York City, similar to how we were looking back at Florida and looking back at Wuhan as they face this oncoming surge, We're now looking forward to try to understand what systems we need to put in place so that we're ready for the fall, should there be a second wave.
Since you brought up indicators, this actually ties into a nice question from Michelle Gargamelli, came in via Facebook Live. There's been some news articles, and I believe this is backed up by peer-reviewed research, correct me if I'm wrong, that the virus may have been circulating, for example, in Italy as early as October or in other places. Is that true? And if it really does spread exponentially and is easy to transmit, why was there this lag? In other words, the next time a pandemic unfolds like this, how long do we really have? Is it months to prepare? Or is it only a few days to a few weeks? Can you educate us a little about those aspects of this?
Our understanding of the early days of COVID-19 is still evolving quite rapidly. I've read the papers suggesting that COVID may have been in Italy, in December, possibly earlier, based on sequencing of sewage looking for viral RNA. I've read reports that suggest it may have been in China earlier. Most of the data that we understand the best at this point, and those would probably be genomes of COVID-19, of SARS-CoV-2, the virus that causes COVID-19, genomes of SARS-CoV-2 that have been sequenced and have been analyzed using methods from evolutionary biology to try and understand when those viruses first emerged, when they first started spreading. They all point to a late November timeframe around when the virus emerged in China and then began spreading in Wuhan, which is very much in line with the case data. I think we will learn quite a bit more in the coming months how much of a chance there is that it was spreading earlier. I think we are still kind of very early days on that, so I would be cautious around interpreting the early studies that are coming out. It doesn't mean that we won't learn that it was spreading earlier. I think it just means that, at least from my perspective, I'm being very skeptical, just given the current amount of evidence that suggests that it was November, December timeframe. One of the aspects of COVID-19 that we have learned is that it is, as I mentioned, highly dependent on these super spreading events for transmission. So 80% of the transmission events trace back to 10 or 20% of people. And so that means that if the outbreak is really going to take hold and start spreading, you have to have a super spreading event. You've got to have something like the Biogen event in Boston to kick off this large amount of transmission. And so as we saw in the West Coast of the United States, that there were some introductions into Seattle that didn't take off. There were some introductions in California that apparently didn't take off because we've retrospectively identified some individuals that died of COVID much earlier than we were aware there were cases. And so what we're seeing really is that the disease does spread exponentially fast, but only once you have a super spreading event or two, which is, again, why mask wearing, test, trace, isolate has been so effective in South Korea, Japan, China, New Zealand, in parts of the US, because if you can prevent those super spreading events, you can really prevent this disease from taking hold.
Dr. Fauci commented that going back to school in the fall was a bridge too far, I think in part because he was worried about whether school kids could act as super spreaders because we shut down the schools so fast, et cetera, that asymptomatic spread through our loved young ones might be a thing that we have to worry about. What's the modeling community's latest take on reopening of schools, and for that matter, the hybrid models that many colleges and universities, both here in the United States and abroad, are contemplating? Are aggregating inside for the very act of learning, which is so vital, going to be a public health hazard at some level?
Most of our experience with pandemics comes from influenza. And for influenza, school children are one of the most important drivers of transmission. It's part of the reason why closing schools is often top of the list as for non-pharmaceutical interventions if there's a novel pandemic. as you alluded to, for COVID, what's clear is that children don't seem to get sick as frequently. And when they do, they definitely do not get as sick. Now, of course, we don't know if there's going to be any longer term health consequences associated with infection. We can just see the short term consequences. So it's possible there are longer term health consequences that we don't know about. But at least in terms of the short term consequences, it's clear that children don't get as sick. One of the things that we are still learning about is, as you alluded to, whether children can be minimally symptomatic or fully asymptomatic and still be a risk of transmitting on to individuals who then can go on to develop severe disease. The data that we're starting to see suggests that children are not as infectious as adults, but it is still very early days for those data. And obviously, given the density of social connections, given the layout of lots of elementary, middle, and high schools, it's very difficult to control transmission, even with mask wearing. And so I think we really need to understand what are the risks to these individuals potentially over the longer term, but then what is the risk that they would then transmit to teachers or transmit back into their households and spark larger outbreaks in communities of individuals that are going to have much more severe disease. So that's something that we're still very much learning about, and is going to influence the decision whether schools can safely reopen in the fall. I think a big part of the university's reopening is tied to the schools reopening. So we know that we have lots of faculty who are caregivers, and whether that's caring for children or other family members, it's essentially impossible to have a full-time job as a caregiver and also have a full-time job as a university professor or as a staff member at a university. And so we're going to have to some way balance the needs of these individuals who will be teaching at universities, who will be working on staff, with their need to provide care for their family, for their loved ones, depending on whether schools, for example, reopen or not. So one of the things that we're going to learn as we move towards the fall is that all of these things are connected. And so really kind of understanding whether the universities might be able to reopen, that probably depends on whether the schools can reopen, but not necessarily because of the transmission, because the professors are going to have childcare, or they're going to have care for other family members that they're providing for, if they're going to be able to go and teach. Now, I do think we know that with mask wearing, with reducing social contacts, you can prevent cases from sparking, large epidemics. And so I do think there are strategies that we can put in place that may mean we could have, a safe, very different but safe, in-person set of classes. But again, that's also going to depend on how this outbreak and epidemic unfolds in the United States. If we're in the middle of a large wave, again in Boston or all over the US, we may not be able to have classes because it will be out of our hands. If we are planning around having our international students come back and we see the kind of xenophobia and racism around immigration in the United States now with the canceling of all these visas, that's of course shifting the entire landscape around so many people's lives, but also very much in higher education. And again, it also comes back to faculty. There are lots of faculty that are relying on H-1B visas, for example, in order to teach, in order to come onto new faculty jobs. And so all of those disruptions have to be taken into account if we're going to decide whether it's safe or not to reopen the university in the fall. And so, it's a very complex and shifting landscape, and certainly one where it's not going to be any one simple answer. It's going to have to be kind of a menu of options to keep people safe that's going to be highly contingent upon what ends up actually happening in the fall with respect to things like COVID, but also immigration.
Yes, your answer really highlights how interconnected we all are. I think that's been a wake-up call for people to see how we depend on so many workers and neighbors, and how our community functions is all very connected. Our economists and social scientists at the Global Resilience Institute are trying to figure out how best to reopen for the governors in some nearby states using that approach. I wanted to thank, by the way, the question on the colleges and school reopening was from Esther Bullitt. So thank you for that, Esther. Do you have any recommendations for the audience about, we're getting questions about what organizations or people should they be following if they want to be COVID aware? Do you have a handful that you could put out there for us?
Yeah, absolutely. So the people that I look to are mostly communicating on Twitter. And so you have individuals like Professor Caitlin Rivers at Johns Hopkins, Professor Natalie Dean, Professor Carl Bergstrom, who are providing accurate real-time information, digesting what's coming out. You have really wonderful journalists like Helen Branswell at Stat News, like Ed Young at The Atlantic, that are putting together really fantastic pieces that, you know, kind of pull apart all of the complexities around what's going on with COVID-19. So those types of individuals are really at the top of my list in terms of who to follow. We're very fortunate at Northeastern both to be embedded in a larger academic community in Boston. So we've got, you know, Harvard School of Public Health, MIT, Boston Children's Hospital, with lots of local experts that are working both in the Boston area, but also nationally, internationally, and the state level. But as I mentioned, the Northeastern News team has done a truly fantastic job of providing information out to the public and out to journalists and out to news sources around the research that we're doing here at the university, but also how, you know, our undergraduates are participating in COVID response. We have individuals that are on co-op in the emergency rooms right now, you know, that are Northeastern undergraduates, you know, some of whom are going off to medical school in the fall. And so all of that kind of information is being provided out through Northeastern News. So I would also put those sorts of organizations at the top of my list for paying attention to as well.
Thank you for that, Sam. I'm going to ask one more question and then we're going to wrap it up, but I'll have a few words for the audience about how they can continue to join in this dialogue after the broadcast is over. So my question is related to how you educate yourself about COVID. What should your average citizen be asking of their local community leadership, whether that's the mayor or if you're in a county that's got county supervisors? What sort of things should people ask through town halls, which of course are all online these days instead of in person? Do you have any suggestions there about what would be reasonable to ask of your local leadership? Because it looks like, as we've heard both from the media and from our discussion earlier, there is not strong federal governance on this whole challenge we face.
I've mostly been involved locally in the Boston area, and that's, you know, primarily because we're based in Boston, and so we have connections to, you know, the city of Boston, to Somerville, to surrounding areas. Northeastern hosted a coalition of 40 area mayors and community leaders just before all the lockdowns went in place to, you know, present our modeling work, to ask and answer questions, to provide them with a forum. And I have really truly been blown away by the work that the local leaders have put in. I think it's a big part of the reason why we were so successful in Boston. I know that it seems like we had a massive wave, and we did, but it could have been so much worse if it wasn't for, you know, our healthcare workers, our first responders, our you know, custodial staff, the individuals stocking our shelves, but also our local leaders who have put in the effort to understand this rapidly evolving situation and make the best possible policies. I think if I was going to ask questions, I would be asking why. And the reason I would ask why is because we're all learning about this in real time, as we've discussed, Mark, from the scientists to the policymakers at all levels of government. And so asking why it is that we have a limit on 10 individuals. And then you can hear from the policymakers, from the mayors, from the city councils, that the reason it's 10, maybe 10 is not a magic number, but it's a small number. And what's important is that we don't have gatherings of 50 or 100 people, because that's how COVID spreads through the populations. And so those are the sorts of questions that I think are going to be really important to ask and answer. And then also, what are the criteria for relaxing or re-implementing measures? What are the triggers for deciding that we might have to have another stay-at-home order? Or what are the triggers for deciding that the restaurants are going to reopen? And do we really think those are the appropriate triggers? Do we really think that this is indicative of being safe to go to restaurants, or just an effort to restart the economy? And so we need to kind of hold our leaders accountable for the ways they are making decisions around how to reactivate or lock down as we move into the summer and the fall.
That's great. So we all need to return to our inner toddler and ask the question why. So I wanted to give a shout out to my middle daughter, Kate, who's a frontline worker in the healthcare system and has helped out at MGH taking care of COVID patients. So thanks to all the healthcare workers that may have tuned in, and first responders for all the important work you're doing behind the scenes. So thank you, Sam. This has been a wonderful discussion about COVID-19. We've been talking with Sam Scarpino. He's assistant professor and head of the Emergent Epidemics Lab at Northeastern University in the College of Science. Thank you for your behind the scenes look at how this has been playing out. And thank you to the studio audience for tuning into our broadcast. If you'd like to catch it again, you can rewatch it here, as well as find it reposted on the Northeastern College of Science news page sometime in the next couple of days. And you can also continue the conversation on Facebook by submitting questions to this post. And we'll try to answer as many of them as we can by checking with Sam and other experts about questions you may have. Thanks again, Sam, for telling us about all the outstanding work you've been doing with modeling. And we wish you great success, and the nation's counting on you. So thanks for helping guide the decision making. And I hope everyone.
Thanks so much for having me, Mark.
Day.